Hello, my name is Andrea Sartore-Bianchi and I'm an oncologist at Niguarda Cancer Center, Ospedale Niguarda, Milano, Italy, and University of Milano. Very glad to participate to this activity about HER2 in colorectal cancer, and I'm delighted to be joined by Dr. Evgeny Yakirevich, who is a pathologist at Rhode Island Hospital in Providence, Rhode Island. So in this section, we will cover the topic selecting the right treatment for the right patient, with a discussion on HER2 testing in patients with colorectal cancer. So I think it's very important to have Dr. Yakirevich as a pathologist, because we know that for HER2 is so important the interaction with the pathologist for oncologists in order to have proper molecular diagnosis of this biomarker. So, Evgeny, speaking about HER2 testing in colorectal cancer, I think that the key questions are when to test and how to test, of course. So, in terms of when HER2 testing is carried out in patients with metastatic colorectal cancer, when most often a clinician at your side or generally it is recommended to ask our pathologists for testing for HER2 in this histology?
Hello, Andrea. It's a great pleasure to participate in this discussion and to share pathologist perspective on HER2 testing. In contrast to breast cancer and gastroesophageal adenocarcinoma, where we have ASCA CAP guidelines for HER2 testing is not specifically included in guidelines for patients with colorectal cancer. So the question, when to test? So for practical reasons, it can be done with the initial molecular tests when we run RAS and microsatellite instability. But usually HER2 testing is only recommended in second and further lines of therapy, and therefore is tested after first line's progression. After patients progress, oncologists are looking for potential targets for therapy, and they request us to check not only for HER2, but in most commonly they request next generation sequencing. And in our institution, HER2 is performed per oncologist request. It's not coming upfront from pathologists.
Yes, I think that it's really interesting to see that starting just a few months ago in the ESMO guidelines, we finally had HER2 testing recommended for all colorectal cancer patients, provided that they are a RAS wild type. So I think this is very important. This is acknowledged also in the NCCN guidelines and that actually mentioned the HER2 testing way before the ESMO guidelines, but also there we have that that patient should not have a concomitant RAS mutation. And this, I think it's very important because there is an enrichment actually in RAS wild type patient as for this biomarker, HER2 amplification, but also specifically from a therapeutic standpoint, we know that a concomitant RAS mutation can indeed preclude the response. So now we use HER2 target therapy only in RAS wild type patients. So I think that this is an important issue, an important factor to take into consideration when we ask for HER2 testing in colorectal cancer. And also, as you mentioned, I think it's important to know that in all countries we have NGS testing upfront, especially for colorectal cancer, because at the end, in colorectal cancer, we have only few biomarkers driving treatment. But in US, for example, I know that it's more widely adopted to have NGS, and therefore, quite often, if you have an upfront NGS, you can test for also for HER2, because of course you have also this biomarker.
Absolutely correct, and I will talk about these advantages of NGS. And depends on the institution. In some institution, this NGS will be performed upfront, in some not. But if we are talking about testing of HER2, there are two well-established testing methodologies, and they are recommended by ESMA and by NCCN. One is immunohistochemistry or IHC, and another one is fluorescent in situ hybridization or FISH. So IHC evaluates the level of HER2 protein expression on tumor cell surface with HER2 specific antibodies. And usually HER2 expression level correlates with staining intensity. IHC is a cheap test. It's easy to do. It needs only one slide. And if it's scored as positive, so HER2 is considered as positive and patient can receive treatment. Or it can be scored as negative. More challenging are these equivocal or 2+ cases, and these cases are reflexed to in situ hybridization or ISH. So ISH uses DNA probes coupled to fluorescent, and then we call it FISH or chromogenic, we call it KISH detection system, to measure copy number of HER2 genes in nucleus. And advantage of KISH that it uses chromogens instead of fluorochromes, and signal may be viewed just in a standard brief field scope. We don't need fluorescent microscope, and these slides can be archived. And there is strong correlation between HER2 expression by IHC and HER2 amplification by ISH. And what NCCN also recommends is next generation sequencing as an additional method for HER2 testing. NGS evaluates all classes of HER2 genomic alterations, which include both HER2 amplifications and HER2 mutations. But in colorectal cancer, amplifications are more common than HER2 activating mutations. So ESMO guidelines, they do not recommend testing of HER2 activated mutations outside of clinical trials in patients with colorectal cancer. So what are advantages of NGS? That it can detect also other genomic alterations such as RAS, RAF in the same assay. And instead of running multiple assays, we'll just run one assay, and this will allow also to preserve tissue, which is very important, preserve patient tissue. However, there are some challenges with this because copy number analysis to tell us the number of this amplification, it's varies depending on library preparation, depending on sequencing technology, on bioinformatics analysis, and it is advisable to perform initial clinical validation to establish amplification threshold in each individual molecular pathology laboratory. And these thresholds can vary between laboratory to laboratory. It's maybe around 6 and maybe around 7, but they have to be established. But in our institutions and in many other, to confirm this HER2 amplification detected by next generation sequencing, we use HER2 immunohistochemistry, and in our experience, the results usually are concordant. We see strong 3+ immunohistochemistry in cases which are amplified by next generation sequencing.
Yes, thank you, Evgeny. I think you provided a very comprehensive overview. And also, to comment from a therapeutic standpoint, I think it's important to know that most of the trial actually carried on with anti-HER2 in colorectal cancer had immunohistochemistry and plus or minus ISH testing as inclusion criteria, but we have also studies adopting NGS. And all these studies with different magnitude but provided positive results. So we are in the situation where we can test with different tools, depending also on the availability that the oncologist has in his hospital. But also NGS, as you mentioned, can provide a reliable diagnosis, molecular diagnosis of amplification. And there are nice report of trying to harmonize the evaluation through NGS of copy number variation with immunohistochemistry, and there is a nice concordance, I would say. So what is interesting, I think, is that there is also a kind of different degree of magnitude of benefit depending on the magnitude of the immunohistochemistry expression and on the copy number variation. So there is a kind of a continuum in the HER2 amplification, and the more the amplified is the tumor, the more expected the benefit, of course. So now we had an overview of testing. I think that what is important at the end of the day, of course, is how to handle this test in terms of therapeutic application. So how, from your pathologist perspective, how these results can inform and guide treatment decision? I think we have also a case report regarding this.
So what we can learn from this case, that with testing by next generation sequencing, we were able to detect target for this patient, which was HER2-neu. Again, it's mutually exclusive from RAS and RAF mutations, and we can see that this tumor was RAS wild type, and we can see that we can confirm this finding or molecular finding by immunohistochemistry for HER2.
Yes, thank you, Evgeny. I think that this is really a case that clearly show how molecular testing, including also HER2, is able to change the natural history of this disease. Because I remember when we developed HER2 target treatment back in 2015 with the first data available, it was really astonishing to see how also in third or fourth or even later line of treatment you can obtain tumor shrinkage and a quite long progression-free survival with basically a chemo-free approach, or using T-DXd, which basically is a monoclonal antibody with a chemotoxic cargo conveying in the cell chemotoxic cargo. So really here we have NGS triggering all the subsequent workup that at the end was included also immunohistochemistry, and we know this is very important, and this case was indeed 3+. So again, we know that the most of the benefit indeed is in 3+ patient, but there are also what we call low expressor. So Evgeny, I think that this is common, for example, in breast cancer, but also in colorectal cancer. So now the difference is that in colorectal cancer, indeed, we know that those low expressors, so 1+ and 2+ without FISH amplification, 2+ without, do not derive benefit from this T-DXd drug and from anti-HER2 treatment. But it's important for pathologists to provide this score and having and for a clinician to exclude the low expressor, for example, to target treatment for HER2 in colorectal cancer. So I would like to thank very much Evgeny for his time and contribution to the discussion, and I always like to have interaction with our colleagues pathologists, because I think it's very important for an oncologist to keep alive this interaction.
Hello, my name is Dr. Kristen Ciombor, and I'm an oncologist from the Vanderbilt University Medical Center in Nashville, Tennessee, in the United States. I am delighted to be joined today by Professor Andrea Sartore-Bianchi, an oncologist at the Niguarda Cancer Center and the University of Milano in Milan, Italy. Together, we will be discussing the subject monotherapy and combination therapy of HER2-targeted treatment in colorectal cancer. So Andrea, could you give us a little bit of an overview of where we stand in terms of HER2-directed therapies for metastatic colorectal cancer, particularly in terms of current guideline-recommended agents?
Yes, Kristen, I think that an important point here is that all treatment that we have that are effective are based on a double blockade, a double mechanism. So when we started investigation of HER2 in colorectal cancer back in 2015 with the HERACLES initiative, with the HERACLES program trial, we adopted trastuzumab lapatinib because based on preclinical model PDX, this was the most effective way to targeting HER2 in colorectal cancer with monoclonal antibodies from the extracellular domain and also a TKI acting on intracellular domain. So in this trial, we achieved a 30% response rate, and this was really astonishing back in that time because these were very heavily pretreated patients, and I think it put the proof of principle that hitting HER2 is an important strategy also in colorectal cancer. Soon after, we had the data from the MY pathway with trastuzumab and pertuzumab, and then more recently data with an ADC. So this is a single drug, but actually having two mechanisms. So T-DXd is very well known also for results in breast cancer, but also gastric cancer. And the Destiny trial also provided a high response rate that was 45% with this drug monotherapy in colorectal cancer. And what is interesting, I think, is that in the Destiny trial, also pretreated patients with a previous anti-HER2, for example, in my institution, the patient were obviously pretreated with trastuzumab lapatinib, and we had response also, the very same response also in this patient pretreated. Then soon after, the Mountaineer trial, and in parallel with the T-DXd trial, was launched. And I think what is very exciting is that based on the data of the Mountaineer trial, tucatinib and trastuzumab were approved by FDA very recently. That was on the 19th of January this year. The ASCO GI Congress was indeed in progress when we had this news, this very good news. So here we have a combination of trastuzumab and tucatinib that is a more potent HER2 inhibiting TKI, more potent than lapatinib, for example. But also here we have the very same strategy of a double blockade, double vertical blockade towards HER2. But here we have a higher response rate, 31.1%, 38.1%, and also especially prolonged PFS of 8.2 months. I think that these are the most important trial. We had an experience also with trastuzumab and TDM1 in HERACLES B, but with a lower response rate, and I think still an interesting PFS. But as far as guideline recommended drugs or combination are concerned, I think that trastuzumab and tucatinib now, for also based on the approval, trastuzumab, pertuzumab, T-DXd, and also trastuzumab and lapatinib are the most recommended regimens in this space.
Great. Thank you so much for that absolutely wonderful overview and really walking us through kind of the different trials that have led us to where we currently are in this landscape. You know, a couple of points I wanted to make that you mentioned in which I found really interesting as I heard the data over the years was, as you mentioned, the Destiny CRC, the antibody drug conjugate trastuzumab deruxtecan. About a third of patients had prior anti-HER2 therapy. So that is really exciting to see that maybe we're overcoming some resistance and that allows maybe some sequencing opportunities in the future. And then as we hear about the FDA approval of tucatinib trastuzumab, looking at the data from Mountaineer and having participated in that study, really looking at the toxicity profile seems very favorable. And really incredible PFS and overall survival. So this is a very exciting time indeed. So as we think about the drugs, this is a good problem to have. Now we have to think about kind of how we select agents and how we sequence these agents. How do you think about that as we are, say you have a HER2 positive patient in your clinic? What are some of the considerations that you think about as you're trying to manage and target the HER2 amplification?
Right. This is indeed an important point because we have data actually only in the advanced setting, I would say in third line. But actually the FDA approval, for example, of tucatinib was at least one prior line of treatment. So it was a second line treatment. Now, I think this is very reasonable I don't think we have enough power to assess and to use a first-line HER2 target treatment together with chemo. And for this, there is a trial ongoing. But as far as second line is concerned, you saw that figures of response rate, and you are not going to get any more better with a second-line chemotherapy, standard chemotherapy in that space of patient, of course, without a driver mutation or without, MSI status. So really in this space, I think that it is reasonable to start considering a HER2 target treatment in second line, and now there is the FDA approval, and to have for all patients this piece of information of HER2 testing in your hands in third line, because at that moment, this is really, I think, mandatory to know that you have a target for treatment for that patient. This is really an important reasoning, and this has to also to change in some way our mind to consider this target treatment earlier on in the continuum of care of colorectal cancer patient. And the other thing to take into consideration is that we clearly show that HER2 is also a mechanism of resistance to anti-EGFR. So this is more retrospective, but it was kind of widely confirmed by several studies in Europe, and we were the first to provide this data, but also US. And what this does mean, it does mean that I think that you have a colorectal cancer patient with HER2 and that did not receive an anti-HER2 regimen, but it is in second line. I think you can go for a HER2 target treatment without having any issue for that patient not having received an EGFR target treatment.
Great points. And I will also, kind of following up on your discussion with Dr. Yakirevich, trying to make sure that the copy number amplification is adequate for this. This is a different disease than breast cancer, say, where breast cancer patients potentially can be treated with some of the anti-HER2 therapies at very low expression levels. So any thoughts on that?
Yes, there is definitely a gradient that can divide the magnitude of benefit. So starting from Heracles, we clearly saw that it was the 3+ patient deriving the most of the benefit, and this was consistently confirmed. If you look at also the Destiny CRC data and those waterfall plot, the color of the waterfall plot, always the 3+ are the guys deriving the most benefit. So this does not mean excluding 2+ with fission predication, but this idea, I think there is an underlying biology that you can detect either by immunohistochemistry, that is the simpler, but also with copy number variation. We clearly show in Heracles the higher the copy number of this patient and the higher the benefit.
Yes. So as we think about what comes next in terms of anti-HER2 therapies, you mentioned, that we don't yet have data in the first line for metastatic disease or earlier stages, obviously, but we're working towards that, aren't we? There is the Mountaineer-03 study, which is currently underway, and that is looking at the combination of tucatinib trastuzumab with FOLFOX chemotherapy in the first line. There's also the ongoing Destiny CRC02 trial, which is looking at different doses of trastuzumab deruxtecan, and interestingly also RAS wild type versus RAS mutant, which is a little bit different given the mechanism of action of the drug. But tell us a little bit in our final minute, kind of what you're looking forward to seeing in terms of further drug development in this area, and what you think some of the most intriguing potential new agents are.
Yes, Kristen, I think you really touch on an important thing, that is the positioning. So we will see about first line. I think there is also an interesting point in using ctDNA, for example. This might help for selection of patient and can be a diagnostic tool that can improve even further the benefit. For example, in Heracles, in a cancer cell paper, we were able to show that those wild type patient in tissue were indeed maybe mutated for KRAS in the blood. So you want to, for example, to exclude that also for HER2. But in terms of drugs, I think that we might see further advances with newer agents. And under this point of view, I think that zanidatamab, that is ZW25, of course, can be an antibody that, bispecific antibody that can be interesting, and also margetuximab, for example. In this case, we have a bispecific with different functions. So it's not targeting two epitopes of HER2, but it's targeting, but it's stimulating the immune cells, providing a more efficient ADCC. So this can be an interesting point for a HER2 treatment, also to enhancing an immune reaction against the tumor. And finally, we have also vaccines and maybe CAR-T cell therapy. Of course, this is an interesting treatments, and we will need to see results and also to understand how feasible can be these approaches as compared, of course, with a drug that can be delivered intravenously easily to our patients.
Yes, it's a very exciting time. I look forward to seeing ongoing developments. So thank you so much to Andrea for his insights today in this interesting discussion. I really appreciate your ongoing work in this area and kind of leading us to where we are today, and hopefully continuing in that advancement of treatment for patients with HER2 positive disease. Thank you so much.
Thank you very much.
Hello, my name is Dr. Kristen Ciombor, an oncologist from the Vanderbilt University Medical Center in Nashville, Tennessee, in the United States. Today, I'm delighted to be joined by Dr. Kelley Rone, a colorectal cancer advanced practice nurse at the Mayo Clinic in Phoenix, Arizona, in the United States. I'm also delighted to be joined by Mr. Scott Wilson, a survivor of colorectal cancer and a patient advocate from Denver, Colorado. Mr. Wilson was diagnosed with stage 4 colorectal cancer with liver metastasis in 2016 at age 48 years. He underwent a colon resection, removing 13 centimeters and 40 weeks of chemotherapy. In August 2017, he was told he had no evidence of disease. He had a liver resection in December 2017 and was on every other week maintenance immunotherapy with panitumumab. Together today, we will be discussing multidisciplinary team care for patients with HER2-positive colorectal cancer. So I'm really glad to be joined by you both today, Kelley and Scott. And I wanted to start off our discussion by talking a little bit about how we think about treatment decision-making, what's important both to the patient as well as the healthcare provider, as we kind of together come up with a plan for the treatment of cancer. So Scott, why don't we start with you? Obviously, you were the patient, and so this was very personal to you. When you were diagnosed and first knew that you were going to be on chemotherapy, sort of what was important when you were deciding on potential treatments and discussing with your healthcare team how you would move forward in the treatment of your disease?
I think the first word that springs to mind is panic. And you know, you're under 50. You've just been told you have a seriously life-threatening condition. Google's just told you that you've got a 10% chance of survival. It's stage 4. And usually in life, when you have panic, instinct kicks in. And we don't have instincts in terms of how to deal with a diagnosis like that. So I think you're really looking for very solid direction and advice at that point, and trust. I had some superb advice from friends in Denver about some people that I could speak to that were very well trusted in the colorectal cancer community. So I was able to reach out to them, find a very strong recommendation for a clinician that would support me. We ended up with 2 fantastic clinicians, one a surgeon, Dr. and one my quarterback, if you like, oncologist, Dr. And as soon as I got to know them and that trust just grew, then your instincts and fear, if you like, subsides a little bit and you start to trust their process. So I think at that point, I just needed very solid, practical advice from trusted experts.
Thank you so much for that. You know, that is, as an oncologist myself, that's what I hope. I hope that my patients trust me and our team, because obviously we're all on the same page and trying to work for the best of the patient. So that's good to hear. But I also totally understand your panic at that diagnosis. No one expects that. And as we're seeing colorectal cancer younger and younger, that unfortunately has become a more common experience. Kelley, could you tell us a little bit about, from your perspective as a healthcare provider, how do you think about patient preferences and priorities as you're thinking about treatments? Obviously, many times we do have options for patients. There may not be one particular right way. How do you think about that, and how do you consider patient preferences as you're thinking about treatment options?
Well, I think it's important that the patient communicate. I think we assume that patients are panicked and afraid, but it's important that we as clinicians encourage our patients to communicate with us what their goals are. If you are a patient who has been told, I have, this stage 4 malignancy, or even if it's stage 3, you have to communicate to your clinicians how aggressive you want to be. If we don't hear from you that you are looking to be very aggressive and attempt to get to a cure, we don't necessarily go that route because we don't know that you want to be aggressive. And so we have to ask, and you have to let us know. And so you have to have a conversation about what your goals are. Otherwise, how do we get there?
I think that's a great point. We as healthcare providers always, I think, naturally think about, okay, what is the most aggressive to get the best outcome? But you're right, patients may have different goals and preferences, and that's really key in determining how we move forward. So thank you. Yeah. Scott, you told us a little bit about which clinicians were involved in your care. I'm curious to hear, how was the communication between you and them, between what your impression of their communication amongst themselves was? Tell us a little bit about that, if you don't mind.
Yeah, of course. And there's a key player that I would introduce here as well, and that's my wife, Ione, as a caregiver. And I don't think any of us can underestimate the importance of the role of the caregiver at that point. So when I talk about panic and, your brain literally goes to mush, it's your caregiver invariably. It's the person that's asking the sensible, practical questions and having those conversations. And there would be moments we would leave the oncologist's office and I would say, Doctor says such and such. Is no, he didn't. This is what he did. So just having that sort of common sense approach from your caregiver, who remembers also going through an emotional trauma at that point. But in terms of the communication from the team, I learned very quickly that these guys do talk, and they're very much looking after my interests in the background. Even to this day, 6 years later, my very first surgeon is still getting reports of all of my scans and that kind of thing. So this almost aftercare service that they've got going on is fantastic. So really, really great teamwork. It was very clear to me that Dr., as I said earlier, was the quarterback. He was the one that was coordinating different options. He was also speaking privately to other groups, when you have cancer tables, if you like, about what are the different surgical options long term. So he was very much my key medical clinical support. But then his team below him would take care of some of the more emotional or practical things that are non-clinical, like skin care or side effect treatment, that kind of thing. That came from the team that's around him. And to me, there's a whole swathe of oncological nurses, which I call super nurses, and just their role in keeping our spirits alive, keeping practical advice, keeping us on track is absolutely invaluable.
That's great. It's certainly something we always strive for, to have good communication amongst ourselves and with our patients. I'm glad that yours was a good experience. Kelley, from a healthcare provider perspective, what are some of the challenges that we face in communication, both with other team members and with the patients? What are some pearls that you've learned over the years in terms of how you can best optimize communication?
I think that one of the things that I've noticed with patients is a lot of times they don't want to tell us side effects that they're experiencing because they think they're normal, or they think if I tell them that I'm having this thing, they may stop my treatment or change my treatment. And so one of the things that I try to express to the patient is, listen, we're here to help you get through this process. You've never had chemotherapy before, and you don't necessarily have the tools you need yet to manage your side effects. Don't assume that you should be having some awful side effect and let it continue. Most of what happens we can manage, but if we don't know what's happening, we can't help you. We can't connect you with the super nurses to make things better. So, I encourage them, you're not bothering us. We want to help you. Our goal is to keep you out of the hospital so that you can stay on track with your treatment. And so we try to express that to our patients. And, sometimes we have to get a little stern with patients and say, hey, why didn't you tell us you were having 10 episodes of diarrhea a day? Well, I thought I was supposed to have that. No, you're absolutely not. And so once we kind of wade through those instances, the patients are like, oh, yeah, you are here. And so they feel a little more comfortable talking to us about what's happening.
Yeah, it's certainly a team approach. And I agree. I have many patients who are very stoic and do not want to talk about side effects or as you said, think that this is normal. And I think setting appropriate expectations of what is normal and what is not, and making sure that patients know that we're there for them, I think is really key.
And I think sometimes people get somewhat embarrassed by some of the side effects that they have. Nobody really wants to talk about how many times they're having a bowel movement every day, or if they're having a lot of gas or bloating. And, we have to make that okay for them so that they don't feel embarrassed by it.
Kelley, as we think about making treatment decisions for patients with colorectal cancer, I feel like it's a very multidisciplinary disease where, the medical oncologist often is sort of, as Scott mentioned, the quarterback, but clearly the other healthcare providers are also integrally involved in making decision-making, in the decision-making process and making plans. How do you think multidisciplinary teams can work best together for the good of the patient?
One of the things that we do at our institution is we do tumor conferences. I think that's a pretty common occurrence at most cancer centers, where we get together. It's every other week for our colorectal cancer tumor conference. And it's a meeting where the surgeons will come, and the colorectal surgeons, and then the liver surgeons, the oncologists, radiation oncologists. We all get together, and patients that are newly diagnosed or who may be having some unusual presentation or response to their treatment, we all get together and talk about the pathology, the imaging, and how can we best treat the patient. And sometimes there are disagreements, and we kind of discuss it and come to a consensus as to how the patient should be managed. And then the oncologist who is in charge of that patient will go back and present the opinions of the group. And then if someone needs to go see a surgeon, say for a liver resection, they'll be referred to that surgeon. And it's just a good way, a more efficient way for people to kind of get together and talk about a patient all at one time.
That's great. I definitely concur with that. The multidisciplinary kind of tumor board approach has been really essential for my practice. And you get different experiences and different perspectives. And I think that's extremely valuable and really benefits the patient overall.
Exactly.
Well, on that note, I'd like to close this part of the discussion. I wanted to thank Scott and Kelley for their just wonderful insights today. I think this has been really informative for all of us, not only here in this discussion, but for our viewing audience. So we hope you found these discussions useful. Thank you. Hello, my name is Dr. Kristen Ciombor, an oncologist from the Vanderbilt University Medical Center in Nashville, Tennessee, in the United States. Today, I'm delighted to be joined by Dr. Kelley Rone, a colorectal cancer advanced practice nurse at the Mayo Clinic in Phoenix, Arizona, in the United States. I'm also delighted to be joined by Mr. Scott Wilson, a survivor of colorectal cancer and a patient advocate from Denver, Colorado. Mr. Wilson was diagnosed with stage 4 colorectal cancer with liver metastasis in 2016 at age 48 years. He underwent a colon resection, removing 13 centimeters, and 40 weeks of chemotherapy. In August 2017, he was told he had no evidence of disease. He had a liver resection in December 2017 and was on every other week maintenance immunotherapy with panitumumab. So Scott, can you tell us a little bit about the side effects that you experienced in terms of with chemotherapy and how your team kind of helped you manage those?
Yeah, sure. And actually, the word you mentioned earlier about stoicism kind of pops into my mind at that point. I was probably one of those patients that kind of held off as much as possible feeding back about side effect because I just wanted the main treatment to really have a chance of doing its job. So my only goal really was survival, and I would sort of take anything that came along with that. Now, along with that did come hair loss or hair reduction, if you want to call it that. So with the colorectal cancer typical treatments, you don't lose your hair completely, but it's certainly thinned from that point of view. A very big side effect was skin sensitivity. I had moved from Scotland, where there's, I think, 30 days of sunshine a year, to Colorado, where there's over 300 days of sunshine a year. So suddenly, you know, this reason for moving became a reason for leaving. And it was a serious challenge. If I just stepped outside for 10 seconds in the Colorado sun, it would have a serious impact of flaring up my face. So I was wearing a mask almost permanently long before COVID kicked in. So that adds a little mental health challenge as well. Of, you know, you're looking different. Why is he wearing a mask, etc. So all those questions go through your head. And then a significant challenge too was neuropathy. And I think that's another example where I may have tolerated the drugs a little bit longer than recommended, just because I thought it was going to help me survive. Personally, I mean, I still have neuropathy in my hands and feet, but I see that as a fair trade-off for survival. Other people might find it more uncomfortable, and I've certainly learned to adapt. And I'll wear 3 pairs of gloves instead of 1, that kind of thing. And there's a Scottish comedian that said, "There's no such thing as bad weather, just inappropriate clothing." So I've applied that philosophy to my neuropathy as well.
Well, I think that's a very healthy perspective, and you mentioned the trade-off. Just imagining what you went through to get where you are. We're sorry you had to go through all of that, to be honest, but we're glad you're here, obviously. How about, Kelley, could you tell us a little bit about, so Scott mentioned sort of some of the treatments that he was on. As we think more about HER2-positive colorectal cancer, which is an increasingly important subset of patients with colorectal cancer, we have lots of new ways to target this disease subtype specifically. And when we think about HER2 targeting agents, what do we think about when we're talking to patients about HER2 targeted therapy? So what side effects can they expect, and what do we look for as healthcare providers as well?
Well, I think the most obvious side effect that we talk to patients about first is diarrhea. A lot of the patients who are undergoing treatment for colorectal cancer have had some sort of surgery on their bowel, and sometimes after surgery their bowels just don't work as they did previously, so some of them are already having some challenges, and then we throw some chemotherapy in that can cause significant diarrhea. Then sometimes patients can get into a little bit of trouble. So we talk a lot about how do you manage diarrhea, how much is too much diarrhea to have, and how do we kind of keep track of that. So we actually have some nurses who call our patients right after their treatment to talk about side effects they might be having, nausea and those kinds of things. And so we educate our patients specifically on how many stools they should have per day before it becomes too much. And so we spend a lot of time kind of looking for those kinds of things. That's the side effect that's the most obvious to people. For us as clinicians, we are watching out for some of that cardiac toxicity. the patient won't necessarily have a clear symptom or side effect from, or an indication that they're having some heart failure from their HER2-directed therapy. But we have to make sure that we watch their echocardiograms and that we make sure that those are being scheduled on a regular schedule, and that we are comparing what they look like previously to what they look like now. And we manage that should it occur. And then the other thing that we look at is, are some of the treatments that we're giving causing lung problems? So we specifically ask, are you having any coughing, any shortness of breath? And if so, we start to investigate.
That's great. Yeah. And I think specifically with HER2-targeted therapies, you mentioned the kind of rarer side effects of cardiotoxicity and interstitial lung disease, and those are really key because you don't want to miss them, and they're treatable. But yes, there are actually much more common side effects that more patients experience. So kind of managing both of those things, the more common, maybe less severe, and then also the ones that are really more dangerous, but might be less common. So I think that's important to kind of keep that top of mind. Now, as we finish up this part of the discussion, Scott, could you give us a takeaway in terms of maybe your best advice for us as healthcare providers who are treating patients with colorectal cancer? What's one piece of advice you would give us?
I think I'm not really in a position to give clinical advice because and everything I found was absolutely superb. I think one of the missing chunks of further development is the mental health side. And I think most of my mental health comfort, if you like, came from outside of the clinical community. It's that broader kind of caregiver community, the survivor community, and really reached into there. And that's the daily challenge. We're all geared up to cope with the physical challenges, but scanxiety, for example, I cannot underestimate the trauma, fear, and torment of waiting for scan results. And it's very difficult for a clinician to walk you practically through what scanxiety means. Sometimes you just need the virtual arm around the shoulder from someone that's been through it. Says, I know what you're going through. I know what it feels like. That's something that clinicians, to be fair, can't really give. So I think just this notion of bringing the broader community in and seeing mental health very much as part of the treatment process, I think would be a major step forward.
I could not agree more. Thank you for bringing that up. I think that's something that's often overlooked in medicine. As we think about developing new drugs and better therapies, which are all extremely important, but helping from a mental health standpoint to get through that journey couldn't be more critical. So thank you for that. Well, on that note, I'd like to close this part of the discussion. I wanted to thank Scott and Kelley for their just wonderful insights today. I think this has been really informative for all of us, not only here in this discussion, but for our viewing audience. So we hope you found these discussions useful. Thank you.